is Sushi. I am one of the PGY3 residents in the Bronx. I work at Jacobi Medical Center and also the Albert Einstein College of Medicine. My presentation today is on the characteristics of traumatic injury in sexual assault patients. I did this project with Dr. McCormick, one of my mentors, who is an assistant professor at the College of Medicine and is also the director of the sexual assault response team at our hospital. I have no disclosures, so some background information. As per data that's published on the CDC's website, 43.6% of women and 24.8% of men in the US experience some form of contact sexual violence in their lifetime. This should make it obvious that unwanted sexual contact is a fairly common event. It's usually presumed that these numbers are grossly underreported. Additionally, communities of color may experience sexual violence at a higher rate. The Bronx houses many of these communities. So our objective was to characterize the severity of physical injuries in cases of sexual assault, and then to identify the risk factors for physical injury in these cases. This is an understudied area, especially in emergency medicine, but is extremely relevant to us as ER physicians since we are often involved in the primary assessment of these patients. So in terms of our methods, we retrospectively reviewed electronic ED records from a high-volume Level 1 trauma center and a nearby community hospital from July 2019 to July 2020 for patients age 13 and above that came in with a chief complaint of sexual assault. Both of these hospitals have a sexual assault response team, also known as a SART team, and are located in the Bronx and therefore receive high numbers of sexual assault cases. For our results, we had 157 patients meet inclusion criteria. 69.4% of patients reported to the Level 1 trauma center and 30.6% of patients reported to the community hospital. 92.4% of patients were female, so they made up the majority. 78% of patients were adults, meaning over the age of 18, and 22% of patients were adolescents. The mean age was 27.9 years old, and our range was from 13 to 79 years. To categorize patients by race, 47.7% were Hispanic, 32.5% Black, 14% white, 4.5% Asian, and 1.3% in the other category. We also categorized the assailant and found 61.2% were acquaintances, 22.9% were strangers, 15.9% were intimate partners, and in 8.9% of cases, the patient reported an attack by multiple assailants. Our results also show that 36.3% of patients exhibited physical trauma on presentation. We then further categorized this into minor injury, described as abrasions, lacs, and contusions, which were 28.6%, and then the remaining 7.6% had major injuries, which included complex fractures and non-fatal strangulation. We did chi-square analysis, which showed an association of trauma with adult age compared with adolescents, and also an association of trauma when the assault was by an intimate partner, which were both significant. 24.8% of cases involved alcohol use, and 14% of cases reported a drug-facilitated assault, but neither were statistically associated with trauma. And then logistical regression determined that assault by an intimate partner increased the risk of non-fatal strangulation. Of note, strangulation is a very high risk factor for homicide. Oftentimes these cases don't make it to the emergency room. Out of our 157 cases, we had 10 cases of non-fatal strangulation. So, in conclusion, in our patient population, major physical trauma and sexual assault cases was significantly associated with an intimate partner. And discussion, sexual assault is a serious issue that emergency medicine physicians often encounter. We need more research and services to help these patients tackle issues that come with physical trauma and intimate partner violence, whether that's in the form of social work or domestic violence abuse counselors, in order to prevent occurrences and or re-victimization. Thank you so much. Any questions?
It's my pleasure to introduce our study entitled Acute Eye Tracking Changes in Vestibular Symptom Provocation in Collegiate Athletes Following Mild Traumatic Brain Injury. My name is Angela Lumba Brown, and I'm an Associate Professor of Emergency Medicine at Stanford University and the co-director of the Stanford Brain Performance Center. Caroline Ueno and Jordan Cornwell join me as co-investigators in this work and in this presentation today. We also present on behalf of Dr. Masaru Teramoto from the University of Utah and Marie Bu from Stanford Sports Medicine and Physical Therapy. The investigative team has no conflicts of interest to report. I'm the award recipient of the Pac-12 Student Health and Wellbeing Grant. As first author on the manuscript, Ms. Ueno will introduce the project.
More than 16,000 sports-related concussions are reported annually by American collegiate athletes. The concussion rate in this group has increased by 60% from the last decade. The Centers for Disease Control cites that the resolution of symptoms is an indicator of concussion recovery. While collegiate athletes typically recover from concussion and return to play within 7 to 10 days, approximately 10% of athletes experience persistent signs and symptoms of concussion beyond 2 weeks. Prolonged concussion recovery time can impact return to activities and quality of life and may result in athletes to return to play prematurely, increasing the likelihood of sustaining another injury. Therefore, identifying objective measures of mild traumatic brain injury has the potential to direct targeted rehabilitation, supporting safer return to sport and patient compliance with clinical recommendations. Clinical presentations of concussion have been classified into cognitive, vestibular, ocular motor, headache, and mood-related subtypes to aid in diagnosis and direct targeted treatments. In this study, we focused on the presentation of vestibular and ocular motor symptoms. Vestibular and ocular motor impairments post-concussion may manifest with difficulty in coordination, reading, balance, and related daily activities, as well as symptoms of dizziness, visual problems, headache, and nausea. The vestibular ocular motor system integrates vision and movement of the head and body to support gaze stabilization and to orient the body in space and time. Concussion may interfere with the transmission of information between the vestibular apparatus and sensory organs, thereby provoking symptoms previously described. Concussion may also impair prefrontal cortex and cerebellar signals to vestibular nuclei, resulting in changes to eye tracking proficiency. 60% of athletes with concussion experience vestibular symptoms, and up to 90% of patients experience ocular motor dysfunction post-concussion, with overlap between subtype groups. We hypothesize that changes in eye tracking may be associated with vestibular symptom provocation. Because previous research suggests that including objective eye tracking measures in subjective symptom reporting may better identify vestibular ocular motor impairment following mild traumatic brain injury, we examined concussion to inform concussion diagnosis associations between eye tracking proficiency and vestibular symptoms to strategize future rehabilitation therapies and inform potential pathophysiologic relationships. Our first aim was to discern abnormal eye tracking metrics following mild TBI in collegiate varsity athletes. Aim 2 identified changes in eye tracking metrics compared to baseline measurements following mild TBI in collegiate varsity athletes. Aim 3 investigated the relationship between post-concussive changes in eye tracking metrics and the change in vestibular symptoms from baseline.
This retrospective cohort study of collegiate varsity athletes analyzed variables related to measures of the vestibular ocular motor screen, also known as the BOMS, and a circular eye tracking application at baseline and within 72 hours post-concussion. The VOMS compares pre-exam vestibular symptom scores to changes in vestibular symptom scores after each of the 7 subtests to identify vestibular impairment. Athletes completed the VOMS within 72 hours post-concussion. The eye tracking application measures ocular motor function through the dynamic visual synchronization of the eye. In the Smooth Pursuits test, the participant tracks a moving target along a circular path and the variability in eye movements is measured. Athletes were assessed on the eye tracking application at baseline and within 72 hours post-concussion. We compared Smooth Pursuits data from the virtual reality eye tracking application to symptom scores following the VOM Smooth Pursuit subtest. We designated eye tracking scores in our dataset outside of the 25th and 75th percentiles as abnormal. The median of the eye tracking data in the present study is similar to reported medians in other studies.
The study examined 119 collegiate varsity athletes aged 18 to 24 years with 177 concussion events. There was a significant increase in the frequency of abnormal eye tracking between baseline and within 72 hours post-concussion, as measured by the standard deviation of tangential error and horizontal gain. Changes in other eye tracking metric scores between baseline and post-concussion were found to be insignificant. The correlations between changes in eye tracking proficiency and vestibular symptom provocation were found to be statistically insignificant.
Mild TBI impairs eye tracking proficiency in collegiate varsity athletes, but change in eye tracking proficiency is not necessarily associated with the provocation of vestibular symptoms. Eye tracking is commonly used as a diagnostic adjunct among varsity and elite athletes and in concussion clinics across the country. This research demonstrates its value in the acute diagnosis of mild TBI, and future efforts may utilize this testing in the emergency department. Thank you for the opportunity to present our work. Further questions can be directed to me and in the future via email at Stanford University.
Hi, this is Ryu Yamamoto. Today, I will be speaking about physician-staffed ambulance and increase in hospital mortality of hypotensive trauma patients. We don't have anything to disclose. On-scene physicians have been incorporated into EMS across the world. However, survival benefits for trauma patients remains unclear. Also, potential delays in definitive hemostasis due to prolonged pre-hospital stay was concerned when physicians were dispatched with EMS crew. So we aim to elucidate effects and harm of physician-staffed medical services on hypotensive trauma patients. We hypothesize that physician-staffed ambulance will be associated with increased in-hospital mortality compared with EMS-staffed ambulance. We used Japanese trauma data bank from 2004 to 2019 that included more than 200 tertiary care centers. We included patients who were hypotensive, that was defined as systolic blood pressure less than 90 mm mercury at a thin, and those who were transported by ambulance. To adjust patient backgrounds, we used inverse probability weighting analysis using propensity scores. At the study setting, I will explain about the capability of crews in Japan. So in non-physician staffed ambulance, so EMS staffed ambulance, they can obtain IV access and they can put the supraglottic airway devices. However, the epinephrine can be administered and intubation can be done in only 80% of crews. On the other hand, physician-staffed ambulance can obtain IO access and can perform needle or tube thoracostomy. And also, depending on resources, they can do transfusion and resuscitative thoracotomy. However, the surgical hemostasis for major bleeding cannot be done even by the physician-staffed ambulance. And this is the patient characteristics. And left side, the data of the left side is before IPW, and the data on the right side is after IPW. And if you look at the data before IPW, you can see the patients who were transported by physician-staffed ambulance were more severe than those who were transported by EMS crew. For example, the patients who were transported by physician-staffed ambulance had higher ISS and higher AIS in the chest. And also more patients who were transported by physician-staffed ambulance were unresponsive at the scene and suffered from cardiac arrest. And also the patient dispatch time were different between two groups. And the patients whose ambulance dispatch time were more than 10 minutes or higher in among patients who were transported by physician-staffed ambulance. But if you look at the data after IPW, these biased distribution of covariates and patient characteristics got even. So we can say the IPW could adjust the patient background. This is the main result of this study. Left side is in-hospital mortality and the right side is pre-hospital time. And patients who were transported by physician-staffed ambulance had higher in-hospital mortality than those who were transported by EMS crews. On the other hand, the patients who were transported by physician-staffed ambulance had higher pre-hospital time, that was 50 minutes, compared with the patients, those who were transported by EMS crew, and their pre-hospital time was 37 minutes. This is subgroup analysis, and the association between physician-staffed ambulance transportation and increased in-hospital mortality remained through the several subgroup analysis, such as pediatrics versus adults, severe injury versus non-severe injury, and also data from early period versus data from late period. However, the patient who were normal tension on hospital arrival, that is the patient who were hypotensive at the scene but got normal tension on hospital arrival. In such patients, the physician-staffed ambulance transportation was not associated with increase in hospital mortality. That suggested the patient who suffered from massive hemorrhage and who cannot be, who could not obtain normotensive on hospital arrival had increased in hospital mortality. As conclusion, physician-staffed ambulance for hypotensive trauma patient was associated with prolonged pre-hospital time and increase in hospital mortality. Thank you.
Hello, everyone. My name is Samuel Wood. I'm a PGY2 at the Reading Hospital Emergency Medicine Residency, and I'm honored to be here at SAEM21. Thanks for having me. So this is our paper. This is titled "The Performance of a Pediatric Scoring Rule for Clinically Important Intra-Abdominal Injuries." These are our disclosures. And let's get to it. So a brief history of PCARN. PCARN is the Pediatric Emergency Care Applied Research Network. You may know them from their child head CT decision rules, but they also developed a decision rule to identify clinically significant intra-abdominal injury requiring intervention following blunt trauma. And they defined intervention as therapeutic laparotomy, angiographic embolization, blood transfusions, or IV fluid for greater than or equal to 2 nights. And their hope was to minimize the use of radiation with more advanced imaging in kids, specifically CT scans. And this was a prospective study involving 20 EDs, primarily in large pediatric academic hospitals, a point which will be important later. So what is the PCARN decision rule? They essentially state that advanced imaging is not required if all of the criteria are met, that being no evidence of abdominal wall trauma or seatbelt sign, a GCS greater than 13, no abdominal tenderness, no evidence of thoracic wall trauma, no complaints of abdominal pain, no decreased breath sounds, and no vomiting. So what did they find? They had 12,044 kids, median age of 11, presenting to 20 EDs. There were 761, or 6.3%, with intra-abdominal injuries. Of those, 203, or 26.7%, received acute interventions. But significantly, their conclusion is that the rule had a negative predictive value of 99.9% in identifying kids who would not require advanced imaging. So they essentially only missed 6 kids out of over 5,000. So pretty impressive. So what did we ask? We asked the question, does the PCARN decision rule, which again was mainly derived from patients presenting to pediatric tertiary care centers, perform as well at our non-pediatric academic center? And we did a retrospective chart review of pediatric trauma patients to identify individuals who required intervention via the clinical decision rule. And we defined no intervention as no return to the hospital within 72 hours. And we had secondary outcomes as stated. Our inclusion criteria were kids less than 18 who were seen in the Reading Hospital ED, pediatric ED, or our trauma bay with blunt abdominal trauma. We excluded those greater than 18 of age. So what did we find? Our chart review went from February 2012 to December 2019, and we had 1,007 pediatric trauma evaluations. 210 of those, or 20%, did not have enough chart data to retrospectively apply the rule. There were 158 of 422 who were PCARN negative, but underwent CT of the abdomen and pelvis anyway. And of note, 5 of 158, or 3.2%, who were PCARN negative did have positive CT findings requiring acute interventions. So 2 went to the OR, 1 needed IR, 1 needed a blood transfusion, and 1 needed IV fluids for greater than 2 nights. Also, of 264 PCARN negative who did not get a CT scan, none of those patients returned within 72 hours or required a significant intervention. So the screening process worked pretty well. So what's our conclusion? So retrospectively applying the PCARN decision rule for identifying pediatric patients at very low risk for intra-abdominal injury would have missed only 1.1% of injuries that required intervention. This percent is greater than prior studies noted in validating the PCARN rule. Remember, the negative predictive value was 99.9% in the original study. But on the positive sense, following the rule at our institution would have resulted in a significant reduction in ionizing radiation, specifically 153 of 422 kids. So ultimately, we conclude that it did well. The clinical decision rule may be appropriate in non-pediatric trauma centers. Our limitations were it was retrospective, and 20% of our population didn't have enough data to accurately apply the rule. We also defined no intervention as no return to the hospital within 72 hours. So if any patients came back after that, there's a chance we could have missed them. So for our discussion, we had 153 of 422 kids who received an unnecessary CT scan. So that's important to note. But there were still 5 that required intervention that would have been missed by the clinical decision rule alone. So this brings up the importance of clinical judgment and the reminder that clinical decision rules are just meant to be adjuncts to ultimate judgment of the provider. So it certainly doesn't substitute for accurate clinical judgment. But still, an overall miss rate of 1.1% is pretty impressive. So we recommend further prospective validation studies, especially in non-pediatric community hospitals, to further validate this rule. But overall, it worked very well. And of course, can't help but mention I am one of many hands who have been on this project. And I want to thank our main contributors, Adam Siegel, Liz Manarelli, Tracy Diener, and all of the rest for all of their hard work on this project. And with that, I will take any questions, and I want to thank you all again for having me.
Hello, this is Yusho Nishida from Keio University School of Medicine in Tokyo, Japan. Today I'm talking about tachycardia and coexisting hemorrhage in hypotensive patients with cervical spine injury, a nationwide study. There's nothing to disclose in this presentation. While hypotension among patients with spinal cord injury suggests presence of neurogenic shock, coexisting major hemorrhage always needs to be scrutinized to rule out the possibility of hemorrhagic shock. On the other hand, bradycardia is known as a typical presentation of neurogenic shock. We don't know if there is a major hemorrhage with presentation of neurogenic shock with normocardia or tachycardia. And even with bradycardia, we still don't know whether there is hidden bleeding which partly contributes the shock. We can say little is known whether heart rate can predict presence of major bleeding in hypotensive patients with spinal cord injury. Therefore, to elucidate the prognostic value of heart rate, we hypothesized that tachycardia on presentation was associated with coexisting major hemorrhage in hypertensive patients with cold syndrome from cervical spine injury. Study design is a retrospective cohort study using Japanese nationwide data source, Trauma Data Bank, from 2004 to 2019. We identified 1,290 adult patients with cervical spinal cord injury who had incomplete or complete cold syndrome and were hypotensive, systolic blood pressure less than 90 on hospital arrival. Patients were divided into 3 groups based on heart rate on arrival: bradycardia less than 60 BPM, normal cardia 60 to 100 BPM, and tachycardia more than 100 BPM. The outcome was major hemorrhage, which was defined as bleeding that needed thoracotomy, laparotomy, vascular repair, or angiography with embolization. And the incidence of major hemorrhage were compared between the groups. Patient characteristics are shown as below. There were 436 patients in bradycardia group, 740 patients in normal cardia group, and 94 in tachycardia group. There were no significant difference in each group for age and sex, but more patients were fast positive and were given transfusion within 24 hours in tachycardia group. And this is the result. The incidence of major hemorrhage was significantly higher in patients with tachycardia. For conclusion, tachycardia on presentation was associated with presence of major hemorrhage in hypertensive patients with cervical spine injury who had cold syndrome. Heart rate would be useful to predict coexisting bleeding among patients with cervical spine injury. Thank you.
Hi, I'm Jacqueline Tran, I'm a medical student, and we have Dr. Shaw here with me. Our study here was on the traumatic pneumothorax and comparing the sizing methods that exist. Next slide. We as authors have no conflicts of interest to disclose. This is the poster that I presented at the medical student symposium at Weill Cornell. It's definitely too busy to get through this whole thing, and so we're going to break it down into pieces for you.
So the idea behind this is that pneumothoraces, especially traumatic ones, are being managed differently, and the size seems to matter. Small pneumothoraces probably can be observed, and we're now putting chest tubes in, so it's important for emergency physicians to be aware of the different sizing methods. In 2019, there was an interesting article that talked about this 35 millimeter rule, which said on CT, if the pneumo is smaller than 35 millimeters, there's a 91% chance that the patient can be observed without a pneumo. We have 5 different methods that we found that are popular in the literature, and we were going to compare these 5 methods.
The objective of our study was to determine how much these 5 guidelines agreed with each other based on the plain film measurements, as well as their agreement with CT, which we consider to be the gold standard. So previous studies that we've seen have compared select chest X-ray methodologies against each other, usually only 2 or 3 at a time, but none of them have really compared their concordance with CT. So we used patients from a level 1 trauma registry from January 2019 to June 2020. We excluded patients that had a concurrent hemothorax, as well as any chest tube placement prior to imaging. These measurements were done by a trained research assistant, which was me, and with the help of a thoracic radiologist. Statistical comparisons were done by our statistician. We used the Bland-Altman and McNamara methods.
So just so you understand a little bit of how these measurements are done, ATS, or American Thoracic Society, is a vertical measurement that you see here in A. The British Thoracic Society uses a horizontal measurement, which you see in B, and you can see how BTS would miss some apical pneumothoraces. The other methods, so if you look at Collins and Rhea, they both use a combination of A, B, and C measurements. And the light method actually just uses a measurement of the pneumothorax in the horizontal plane that looks at the size of the pneumo compared to the entire hemithorax. So they're all a little bit different. If we look at CT, the measurement is done from the wall to the pleura to the mediastinum. And if it's more than 35 millimeters, it's considered large. If it's less than 35 millimeters, considered small.
We ended up with 34 patients at the end of our study. We started off with 108, but the remainder of them didn't meet our inclusion criteria because they either had a pneumothorax or chest tube placed prior to imaging. Most of our patients were male. The median age was 61 years, which is slightly older because of our Upper East Side population. We ended up with 15 CTs that were used for comparison, along with the 34 chest x-rays. 73.5% of our patients ultimately required tube thoracostomy. And notably in our results, when we compared ATS and BTS guidelines, if you remember, ATS was the apical single measurement and BTS was the single horizontal measurement. They reasonably made considerably different predictions for small versus large pneumothoraces, with ATS estimating larger pneumothorax size.
When we compared the various methodologies, you can see there's a lot of variation. The confidence intervals are pretty wide right here in the middle. But when we separate them to dichotomize them to small and large pneumothoraces, there was definitely some agreement between Collins and Light and Rhea. But really, when we look at compared to CT, the only two methods that showed agreement were ATS and Collins. So those are the two that we think are probably more valuable for the emergency physician. We did some fancy statistics in the background, but too complicated for this 6-minute presentation.
So our notable conclusions are that, as I mentioned, ATS did estimate larger pneumothorax size compared to BTS, likely because they picked up more apical pneumothoraces, and the horizontal ones are harder to detect on chest x-ray. There was significant variation among all the sizing methodologies as expected, as you can see based on the criteria that they all require. Collins and ATS, as we mentioned, were the more accurate ones when we compared their concordance with CT. Again, that just means that they're more probably clinically relevant and able to be used in the emergency department. The Collins method, however, is not as easily applied because it is a complex formula. So ATS might be easier because it's that single apical pleural measurement. Again, though, the utility of ATS measurements is limited to apical pneumothoraces versus the other methods incorporate multiple interpleural measurements. Further studies are definitely necessary with a larger sample size to kind of confirm and explore our results. And this is our references. Thank you so much for coming to our talk.
Thanks, everyone.
Hello, everyone. My name is Siri Valori, and I am a third-year medical student at the Rutgers, New Jersey Medical School. The title of our project is Epidemiological Trends of Pediatric Open Globe Injuries, or OGI, in the United States. The authors include myself, Parth Patel, Dr. Valori, Dr. Zarbin, and Dr. Bhagat from the Institute of Ophthalmology and Visual Science at the Rutgers, New Jersey Medical School. We have no financial conflicts of interest to disclose. This project was not funded by any external grants. The purpose of this project is to identify epidemiological trends of consumer product or CP-related pediatric open globe injuries, or OGI, that presented to the emergency department, or ED, in the last 2 decades. To give some background regarding the incidence of ocular injury, in the United States, about 700,000 eye injuries occur annually in children. Open globe injury is the most severe injury that results from a full-thickness defect in the sclera. Pediatric OGIs can result in significant vision morbidity as a result of amblyopia in many cases. Individual institutional studies in the literature have documented epidemiological trends in pediatric OGIs, and our project adds value to the literature by assessing trends on a national level. The National Electronic Injury Surveillance System, or NEISS database, was used in our project. The database was used to identify cases of OGI in the pediatric population, which we defined as being from ages 0 to 20. We identified cases that occurred between 2000 and 2019. In total, we identified nearly 7,600 cases of pediatric OGI. Cases of OGI were identified based on the narrative description of the injury and the patient's admission status, as documented in the database. All cases of OGI that were treated and transferred, admitted and treated, or admitted and placed in observation were included in this analysis. Descriptive analysis was performed using IBM SPSS 23. You can see some of our results visualized here. Of the total 7,599 cases of OGI that were identified in the pediatric population, we stratified the cases by sex, race, location of injury, and age. As visualized by our graph here, the majority of cases were male at 74.7%, white at 50.8%, and occurred at home at 45.8%, when stratified by sex, race, and location of injury. Regarding age, we found that 46.5% of cases occurred in children ages 0 to 9, while 53.5% of cases occurred in those ages 10 to 20. In addition, we have our other notable findings listed here. The plurality of cases occurred in the month of May at 12.2%, and on Saturdays at 22.3%. The most common products associated with the OGIs were sports and recreation-related products at 32.0% for the total pediatric cohort. When comparing pediatric OGIs in the 0 to 9 age subgroup to OGIs in the 10 to 20 subgroup, further trends were observed. In both groups, males composed the majority by sex, but in the 0 to 9 age group, the ratio of males to females was 2 to 1, while in the 10 to 20 age group, the ratio was 5 to 1. In addition, when comparing the two age subgroups, while the home was the most common location of injury for both groups, the prevalence of home injuries was twice as high in the 0 to 9 age group than the 10 to 20 age group, with the data being 63.7% for the 0 to 9 age group versus 30.3% for the 10 to 20 age group. Furthermore, among OGIs in the 0 to 9 age group, the most commonly associated consumer product was kitchenware at 26.9%, while in the 10 to 20 age subgroup, OGIs were most commonly associated with sports and recreation-related products at 45.5%. In conclusion, we found that among the cohort of pediatric OGI cases identified as presenting to the ED between 2000 and 2019 of patients ages 0 to 20, the majority of cases occurred in males, whites, and occurred at the home. When comparing pediatric OGIs in the 0 to 9 age subgroup to the 10 to 20 age subgroup, the prevalence of home injuries was twice as high in the younger age group. Furthermore, most OGIs were caused by kitchenware in the younger cohort, whereas the most common cause was related to sports in the older cohort. We believe these findings, among national trends in consumer product-related open globe injuries, can help inform safety guidelines for the pediatric population. For more information, I can be contacted via my email address on the slide. Thank you for listening to my presentation.
Hi there, my name is Avnish Bengu. I am a second-year medical student at Queen's University in Kingston, Ontario. Today I'll be talking about my study, assessment of non-technical skills of the trauma team through video review to improve team communication. Now, 70 to 80% of healthcare errors are actually due to poor communication. Specifically within the trauma bay, communication techniques are currently diverse and present opportunity for errors. Things like misunderstanding, a hesitation to speak up, or interruptions are common within the trauma bay. As such, there's value in implementing standardized communication measures. Things like a call-out when a team member relays an important piece of information to the rest of the team, or closed-loop communication, which is when an operator provides a command, a receiver acknowledges that command, and then repeats it back to the operator to make sure that they fully understood and close that loop. Now, the aviation industry realized there's value in assessing team performance as it's been shown to improve teamwork and reduce risk. An example of this tool is the non-technical skills scale, which has since been adapted for healthcare and been validated using video review technology. As such, our objective was to identify communication gaps during the assessment and management of severely injured trauma patients in the trauma bay using the Trauma Non-Technical Skills Scale and the largest Canadian Level 1 trauma center. Furthermore, we aim to develop strategies to improve team performance. We did this by having 2 reviewers independently assess non-technical skills of team members using the Tinotex tool via video footages at Sunnybrook Health Sciences Center. In total, we collected 55 cases worth of data for our study. In terms of primary outcomes, we looked at team performance assessed using Tinotex across 5 different domains: leadership, cooperation and resource management, communication and interaction, assessment and decision-making, and finally situation awareness or coping with stress. In terms of secondary outcomes, we looked at the number of call-outs, the number of times closed-loop communication was complete or incomplete, and the number of parallel conversations. Finally, the perception of need for closed-loop communication by trauma team members was assessed using a questionnaire. Here you can see an example of the Tinotex tool that was used by our data reviewers, delineating the 5 different domains that were highlighted earlier. In terms of patient demographics for our study, you'll see the term ISS. ISS stands for Injury Severity Score, where a score greater than or equal to 16 was considered to be more severe, whereas a score of less than 16 was considered to be a less severe case. In our study, 37% of our cases were considered to be more severe. Now, interestingly, looking at our primary outcome, we can see that communication and interaction scored significantly lower compared to all other domains on the Tinotex scale. This was assessed using a Wilcoxon signed rank test. Now, looking at secondary outcomes, we can see that the number of callouts and the number of times closed-loop communication was properly completed was greater in more severe cases compared to less severe cases. Now, this comes as no surprise, as in more complex cases, we expect to see more collaboration and more communication between team members, and so we would expect to be you would expect to see more callouts and closed-loop communication. More importantly, though, we can see that there were a number of times that closed-loop communication was initiated and not properly completed, as well as a number of parallel conversations, irrespective of case severity. Finally, looking at questionnaire feedback from trauma team members comparing current impression on flow of communication versus overall desirability for the implementation of a better standardized closed-loop communication structure, we can see that there is a strong positive impression indicating an overall desirability for better standardized closed-loop communication structure in the trauma bay. Looking in total at these results, there were many incomplete and missed opportunities for closed-loop communication. Parallel conversations unrelated to patient care were also common. This ultimately led to a relatively lower communication score on the Tinotex domain. Now, closed-loop communication was often not completed when communication wasn't directed towards a specific team member. This might actually be due to the high level of trainee turnover in the trauma bay, who often have limited training in crisis resource management, which implement closed-loop communication techniques. Furthermore, there is a slightly positive impression on current flow of communication and closed-loop communication. However, there was also a desire for the implementation of standardized closed-loop communication structure within the trauma team. As such, we can conclude that a lower communication score using Tinotex was identified and caused by incomplete closed-loop communication and parallel conversations. This was reflected in survey results, which emphasized the need for improved closed-loop communication. In terms of future initiatives to address this gap, we aim to do so in a number of ways. Closed-loop communication training will be used in situ simulations within the trauma bay while managing challenging cases. We also plan to improve compliance with the pre-briefing checklist prior to patient arrival to reinforce more frequently the need to keep closed-loop communication during patient care. Thirdly, we'll continue discussions at trauma team video review meetings. And fourthly, We plan to create a mandatory educational video on crisis resource management and teamwork for all incoming trainees. Thank you so much for listening to our talk.
My name is Sam Paskin. I'm a resident physician at Denver Health. I'll be presenting a quality improvement study entitled "Is Observation for Blunt Abdominal Trauma Necessary Following a Negative Computed Tomography Scan?" Here's my obligatory disclosure slide. I have none. And we'll start with a little context for the QI project. Trauma is the third leading cause of death for patients under the age of 45, with a large proportion of those due to intra-abdominal injury, solid organ, hollow viscous, mesenteric. Physical exam is notoriously poor at identifying these injury patterns, as were earlier diagnostic modalities. Thus, it became standard practice to observe these patients for upwards of 6 to 8 hours to allow for possible radiographically occult injuries to declare themselves. Physical exam at its very best, such as seatbelt sign and abdominal tenderness, operate with sensitivities of 40 to 50%, but these numbers drop off significantly in the setting of altered mental status, intoxication, or distracting injuries. DPL, now antiquated, introduced in the 1960s, was able to identify injuries producing large volumes of free fluid in the abdomen, but insufficient in ruling out all other forms of intra-abdominal injury. Earlier forms of CT, such as in the 80s, were specifically noted to be limited in sensitivity for bowel, diaphragmatic, and pancreatic injuries. POCUS, ubiquitous in the emergency department now, and an incredibly useful tool for real-time diagnostic decisions and early identification of sick patients for disposition to the operating room, continues to have sensitivities as low as 60% documented, thus insufficient to definitively rule out blunt abdominal trauma. Which brings us to the modern-day multi-detector helical CT, with a wealth of data reporting sensitivities of 98 to 99% for intra-abdominal injury. But we know clinical policy lags behind data. Our ACEP policy from 2004 appropriately stated that CT was insufficient to rule out intra-abdominal injury, specifically identifying bowel, diaphragm, and pancreatic injuries as being missed at high rates. But almost a full decade later, our policy still lags, supporting observation of the radiographically cleared individuals and lacking definitive support for early disposition of CT cleared individuals. This coming from an ACEP policy update in 2011. At our own institution at Denver Health, we continue to operate on an ED-driven rule out blunt abdominal trauma observation window. Patients identified as sick meeting pre-hospital trauma activation criteria or requiring trauma consultation for their illness in the emergency department, if clinically appropriate, were often imaged with CT abdomen and pelvis trauma protocol. Those with identified intra-abdominal injuries would be dispositioned as such. Those without any identified injuries would be put into a 6-hour window for rule out blunt abdominal trauma, during which white blood cell count, hemoglobin, and abdominal exams would be serially obtained, and ultimately the majority of which would be discharged to home with no new identified injuries. Begging the question, if we know these patients are going home ultimately, why put them through a prolonged ED observation window? This was the impetus for our QI initiative. The emergency department and trauma services collectively agreed to trial a change in our rule out blunt abdominal trauma paradigm. Instead of our 6-hour rule out blunt abdominal trauma window, those without high-risk features who had been radiographically cleared would be discharged, and those with, such as equivocal CT findings, seatbelt sign, or persistent severe abdominal tenderness, were admitted to trauma to definitively rule out blunt abdominal trauma. We performed a retrospective observational study with abstraction of 12 months of consecutive patients before and 6 months after this protocol change. Our inclusion criteria included age greater than or equal to 18 years, blunt trauma mechanism, and CT trauma protocol obtained during part of their ED workup. Our cohort included 1,594 patients, 1,001 before and 593 after protocol change, 90% of which presented by ambulance, 59% ESI 1 and 2, and 38% of which met trauma activation criteria per our institutional guidelines. Our injury mechanism distribution included 40% motor vehicle collision and 20% fall, closely mirroring that of other reported data. And we identified intra-abdominal injuries on CT in 10% of our patients, just slightly below the published prevalence. The patients observed in the ED to definitively rule out blunt abdominal trauma decreased from 15% pre-intervention to 5% after, effectively decreasing the length of stay for all comers by a half hour and over 105 minutes for those ultimately discharged, with no increased rate of missed intra-abdominal injury. Leading to our conclusions that modern CT scanners are highly sensitive for intra-abdominal injury, and in patients with a negative CT normal mental status, and no high-risk features, further observation in the emergency department to rule out blunt abdominal trauma is unlikely to identify additional injuries and unnecessarily prolongs ED length of stay.
Hello, my name is Anna Glasser. I'm a second-year medical student at the University of Utah. Today, I will be presenting our abstract, Current Balloon Management During Endovascular Balloon Occlusion of the Aorta in Animals, a Scoping Review. I have no financial COIs to disclose. 4 of our authors have their disclosures listed for Certis Critical Care. Non-compressible torso hemorrhage is a major contributor to mortality in trauma medicine. Operative management is the main intervention. However, in situations where operating rooms are not immediately available, additional procedures are valuable in mitigating mortality. Resuscitative endovascular balloon occlusion of the aorta, also known as REBOA, is an emerging adjuvant therapy. So what exactly is REBOA? This endovascular approach introduces a balloon catheter, often through femoral artery access, into the aorta superior to the site of hemorrhage. Upon inflation, the balloon maintains perfusion above the site of occlusion while preventing blood flow below. This image shows the various zones of occlusion. Zone 1 is above the celiac trunk. Zone 3 is below the inferior-most renal artery, and Zone 2 is in between. This image demonstrates full inflation within the aorta, which completely halts flow inferior to the balloon. This particular balloon management strategy goes by a few different names, but I will refer to this as complete REBOA or C-REBOA for our purposes. Endovascular techniques have a lot of promise as a non-compressible torso hemorrhage supplementary management. However, long periods of occlusion come at a cost, including ischemia reperfusion injury. This leads to end organ damage, often seen in the heart and kidneys, and hemodynamic instability. As one might imagine, a balloon inflated in the aorta prompts distal ischemia, proximal hypertension, and rebound hypotension upon deflation. Newer balloon management strategies have been developed to mitigate these REBOA-associated complications. The first is partial REBOA, or P-REBOA. The balloon volume is titrated based on target parameters such as blood flow or blood pressure. The second strategy is intermittent REBOA, or I-REBOA. This is a strategy that alternates between complete occlusion and complete deflation based on a target time or proximal blood pressure. The goal of both of these strategies is to allow blood flow past the point of occlusion to provide some distal perfusion. With limited data in humans, the best option to mitigate injury is still unknown. Our scoping review aimed to map the literature on REBOA balloon management strategies for non-compressible torso hemorrhage in large animal models. With 2 information specialists from the University of Utah Eccles Library, we generated a search query that was applied to various databases from inception through June of 2020. Screening was completed using Covidence, and data was charted using a descriptive approach. 648 studies were identified. After title abstract screening and full text screening, 58 studies were included for our scoping review. The earliest studies were performed in 1988. As you can see, complete REBOA is the strategy most researched over time, but there have been more recent increases in both partial and intermittent studies. A large majority of the studies were conducted in pig models. Other animals assessed were sheep, baboons, and dogs. Additionally, Zone 1 was the main zone of balloon inflation with 49 studies. Zone 3 was conducted in 11 studies, and only 1 study looked at Zone 2. Markers to assess for REBOA-associated injury were varied across studies. Ischemia reperfusion injury was captured by serum lactate concentration and pH, which were obtained most often. Markers for acute kidney injury and myocardial injury were explored less frequently. Laboratory values of urine output, serum creatinine concentration, serum potassium concentration, and histopathology assessed acute kidney injury. Serum troponin concentration and myocardial histopathology were least explored, reflecting less investigation of myocardial injury. Complete RIBOA was the balloon management strategy most investigated, followed by partial RIBOA, then intermittent RIBOA. Further, a smaller proportion of studies directly compared balloon management strategies. 13 studies compared complete to partial RIBOA strategies. 3 studies compared complete to intermittent, and only 1 assessed differences between partial and intermittent RIBOA strategies. In conclusion, studies of RIBOA managed non-compressible torso hemorrhage were primarily conducted in zone 1 of the aorta and in pigs. Despite recent increases in exploration of alternative balloon management strategies, complete RIBOA remained the primary strategy assessed. Studies comparing various balloon management strategies in animals were limited, and investigation of RIBOA-associated injury was inconsistent. Further animal studies comparing complete, partial, and intermittent RIBOA are needed to determine the ideal balloon occlusion strategy for management of non-compressible torso hemorrhage to drive future clinical trials. Here are my acknowledgements. Thank you so much for this opportunity.
Good afternoon. Today we are going to discuss the effect of COVID-19 on ED error. ED volumes dropped more than 40% across multiple healthcare systems in the US at the onset of COVID-19. Multiple theories have been suggested for the decrease in ED volume, one of which was patients' fear of contraction of the virus while coming to the ED. Patients also expected excessive wait times. They thought there would be an unusually large number of critically ill patients swamping the ED. Patients also perceived the need to conserve space for the critically ill. By doing so, many patients belittled their own illness and came in later sicker than needed. In addition, patients were also afraid that the quality of their medical care would be compromised for the following reasons. Patients assumed that multiple healthcare workers would be of compromised health. Patients also anticipated a staffing shortage due to illness or quarantine. Patients also assumed there would be unwillingness of staff to work at the height of a pandemic. We know already from previous studies that quality and timely delivery of emergency care, such as workload and time pressure, have been associated with error. Knowing this, we might expect a decrease in volume with less deterrence to quality healthcare would result in a commensurate decrease in error. On the other hand, COVID-19 introduced additional complexity to healthcare, potentially increasing error. The patients that were coming in were patients of higher acuity. There were suddenly distractions to usual care due to donning and doffing PPE and practicing social distancing. There was uncertainty in presentation and outcomes. This was a newly discovered virus. There were suddenly new symptoms appearing every day, and the outcomes were completely unknown. There were also potential dangers in the workspace itself due to concerns like, do my colleagues have COVID? The objective of our study was to determine whether a decrease in ED volume affects the rates of error in the ED. This was a prospective observational study. We looked at Q2 2020, which was from April to July, and we compared Q2 data from previous 3 years. Our data collection mechanisms were 72-hour returns with admission upon return, patients that were transferred from the floor and then to the ICU in under 24 hours, and patients that died within 24 hours of ED arrival. We also looked at physician or patient quality of care complaints. These are our results in a detailed fashion. I will explain them briefly. In 2020, 7,001 cases were screened. Out of those, 378, which is 5%, met our review criteria. When comparing 2020 to 2019, ED volume decreased by 35%. Compared to 2018, 38%. And compared to 2017, 50%. The overall incidence of error during the pandemic was 7%. Looking at individual errors based on our data collection mechanisms, when comparing to 2019 and 2018, there were no statistically significant differences. Comparing 2020, 2019, and 2018 to 2017, all three more recent years had significantly less error. The overall incidence of error among all ED patients compared to the same quarter in each prior year was not significantly different. However, our study does have limitations. This is a single institution study, so that may limit generalizability. As 7,000 records were screened, but absolute numbers of cases meeting our narrowly defined criteria were small. However, these numbers do not differ significantly from prior studies of error. In conclusion, the overall incidence of error in the ED was low. However, decrease in ED volume during COVID-19 did not change ED error rates. This is likely multifactorial, related to acuity, and also we did decrease our patient contact times. We did whatever we could. So we had limited examinations, and we also had a lot of what we did was virtual. So we had a lot of virtual messaging, and we actually even sent in robots to patient rooms as to limit patient contact times. All of this because of apprehension related to exposure to the virus. Thank you for listening, and I would love to answer any questions.